So we are now on part 4. Redo again because the sound quality was disrupted on that original video, so I'm redoing it. I also think I solved it. I think you cannot record in QuickTime if you are currently uploading your video to YouTube. So I was trying to do things too quickly, and I think that's the problem. So anyways, if you guys ever do recording, now you know if you're using the free software on your Mac, you can only do one thing at a time. Okay, so strep throat is what you're used to calling streptococcal pharyngitis. It only has symptoms of a fever and then the throat itself, right? So an incredibly painful sore throat that typically has pus on it, which you can see on the tonsils here. It'll be red, and that's about it, right? So it hurts to swallow, hurts to talk because your throat hurts, and typically you'll have the pus on the tonsils, and that's it. So if you have any other symptoms, congestion, upset stomach, anything else, it's probably not sore throat. It's probably not strep throat. Also, strep throat is an incredibly painful infection. It's not your regular sore throat. So anyways, we do prescribe antibiotics for these infections because the bacteria Streptococcus pyogenes can occasionally cause side effects, including if it spreads to another area of the body, that can be very dangerous. So we want to make sure that you don't get endocarditis, but we also want to make sure that you don't get rheumatic fever. And we'll talk about rheumatic fever in a moment. Let's finish up talking about this slide. So beta hemolytic or beta hemolysis. This refers to the ability to completely break down a red blood cell on a blood agar plate. But it turns out it can actually break down any tissue. And that's why it can also cause, flesh-eating skin disease if it gets into your skin. Okay. Organisms, different species of Streptococcus that have beta hemolytic properties are categorized as Group A Streptococci, or GAS for short. And it's unfortunate that they call it Group A when we're talking about beta hemolysis. I wish they would have thought about making it easier for people, but that's the case. I'm not the one in charge. All right, so Streptococcus pyogenes is resistant to phagocytosis. It can just kill phagocytes. We have rapid tests for this because it is fairly common, especially in children. And so you go to the doctor with your incredibly sore throat. You say, I think I might have strep throat. They take a swab of your throat and stick it in a rapid test. But they also will then send it to culture. Sometimes they do more than one swab, so that one swab's dedicated to the culture and one's for the test. Sometimes the swabs are actually like on the one handle that the doctor holds. There'll be like 2 swabs, and one swab gets broken off, put in to the lab for culture. Anyways, you get the point. You need to culture it and confirm that it is Streptococcus pyogenes, but you also need to confirm that the antibiotics will work. So we do have antibiotic resistance issues with this as well. So we have to always confirm antibiotic sensitivity. Okay, so Streptococcus pyogenes can cause a range of other diseases. And so one of those is scarlet fever, which is not so common anymore in the United States, but it's still very much common in developing countries. So I already mentioned that Streptococcus pyogenes is most affects ages 5 to 12, right? Children. Scarlet fever is a hypersensitivity reaction. So the immune response is actually causing these symptoms of high fever and this rash. Okay, so let me show you these images. So incredibly red and swollen throat. You can start to get a rash on the tongue and then on the body as well. This rash actually begins flat, as I put here, like it's just red blotches, but then it will turn to fine bumps and feel like sandpaper. And so that sandpaper rash is a huge characteristic of scarlet fever. It's how it, one way that it stands out among other types of rashes. You can have nausea and vomiting with this as well. Complications, as I mentioned, with any Streptococcus pyogenes infection or any group A gas, right? You can have endocarditis, but you could also have rheumatic fever, and rheumatic fever means that you end up getting inflammation of the heart, the joints, the kidneys, and this can lead to permanent scarring, permanent damage. So to avoid these complications, we will always prescribe antibiotics for Streptococcus pyogenes infections, or in other words, group A streptococci are always treated with antibiotics to prevent these complications. Okay, so why scarlet fever is so different than strep throat, right? So this is actually very interesting. This strain of Streptococcus pyogenes that causes scarlet fever is actually infected with a virus, with viral DNA, and it's the viral DNA that's producing this protein that the body views as a toxin, and that causes that reaction. And we're going to see another example of this later on in our survey, okay, of this bacteria that's infected with a virus that causes a particular outcome in our body. This seems to be becoming less and less common in developed countries, right? But it is still happening in developing countries. All right, so, and yeah, I already talked about that. So we've talked about Streptococcus pneumoniae a little bit. Fever, chills, cough, rapid breathing, difficulty breathing, chest pain, all symptoms of pneumonia, right? So the alveoli are infected with the Streptococcus pneumoniae, and that causes them to fill with fluid. And this interferes with the ability to exchange gases between the alveoli and the capillaries that wrap around it, right? So that in and of itself is a severe life-threatening disease, right? Pneumonia. But furthermore, you can have complications where it crosses the blood-brain barrier, gets into your central nervous system, and can cause meningitis. So because that is so serious, we also have the vaccine to prevent this. Also notice that Streptococcus pneumoniae is encapsulated diplococci. Looks just like Neisseria and not gonorrhea, right? But the pneumonia causing one. Okay. So I don't know why this isn't here twice. Sorry about that. All right, so now we can move on to a different group called Actinobacteria. These are gram-positive, but now we're looking at high GC content, right? So those base pairs of DNA. There's a lot more G and C base pairs than there are A and T in this group. And they're all gram-positive. And these are really interesting because they have fungal properties. They are very similar in appearance and or even reproduction, like a fungus. So super bizarre group of bacteria, and also very significant. We get two-thirds of all of our antibiotics have come from Streptomyces, and Streptomyces is a genre, right? A genus. There's different species of Streptomyces, and those different species have given us different antibiotics. Of course, those belong to the group of Actinobacteria, fungi-like bacteria. We also have corynebacterium, which causes, if you are looking at the species Diphtheria, then you're looking at the disease diphtheria. I have another slide to talk about that. Significant disease, right? Nocardia, I'm not going to give you a bunch of information about, just know that it can cause pneumonia. And for Streptomyces, I'm not really going to give you much more than what's on this slide. Just know that it is very bizarre, right? It looks like a fungus, and it even reproduces similar to a fungus in that it will produce spores that are the reproductive source. This is not the same as endospores. Endospores are a dormant survival mechanism of just a few types of bacteria that are able to do that. This is a spore, like a fungal spore, for reproduction. Okay, very different. You can look in your book about Streptomyces. They'll help explain in a little bit more detail how it looks and behaves very much like a fungus. This image here is to show you Mycobacterium. And Mycobacterium, you should know for tuberculosis, severe respiratory infection, and also there's a species of Mycobacterium that causes leprosy, right? So Mycobacterium leprae causes skin infection, which actually damages the nerves and can lead to losing, fingers and toes and things. It's an awful, leprosy is an awful disease. And we used to, didn't know how it was transmitted or how to treat it back, long time ago. They would just exile people into the outer skirts of the cities just to try to keep it away, to keep it from spreading to more people. And these people lived very lonely, sad lives of being, exiled from their family and friends. Like, they could not visit. It was a very strict rule to prevent more people from getting this disease that they didn't understand. But nowadays, we can actually just treat it with antibiotics. We can prevent it from getting to the extreme form of the disease as well. And the reservoir, there can be more reservoirs, but one of the reservoirs are armadillos. So you should never, never go touch and play with wild animals, because you don't know. First of all, they could hurt you, maybe scratch, bite, right? And even if they don't hurt you, like playing with frogs and things, they can have all sorts of different microbes that can harm you. Okay, so you should always take care when interacting with animals, wild animals. All right, so we're going to first talk about tuberculosis, and then we'll circle back to the first part of this slide with diphtheria. Okay, so tuberculosis is caused by Mycobacterium tuberculosis. Remember, that's an acid-fast organism. It will, on the gram stain, it will give you a mixed outcome. The majority should be gram positive, but you'll have some that look possibly gram negative. It gives you this confusing outcome. And so then you have to do the acid-fast staining test, remember. And because it has that mycolic acid substance, that like waxy substance outside of its cell wall, it will not decolorize when rinsed with the acid alcohol. So that's why we call it acid-fast. It's resistant to the decolorization. So recall all of that from our previous lecture. Now you get to learn a little bit more, a lot more about the actual disease. So we do have a strain of Mycobacterium called Mycobacterium bovis found in cows, right? Bovine. So cow or dairy products can potentially transmit that strain to humans. It's less than 1% of all US cases. So we don't consider this like a huge risk, but it does exist, and it would give you the same symptoms of tuberculosis. Okay, but it's a different strain. Now, nearly 1/3 of the entire global population has tuberculosis infection. This is a huge medical problem, right? We really need to get this under control, and we've got it under control in the United States. We've got it under control in other developed countries, but that's, as you can see, it's still a major problem. Okay, so this, we estimate about 2 million deaths each year. This could be an underestimate. We also have been seeing a relationship between tuberculosis and HIV. A lot of populations that are TB positive are also HIV positive, and this is most likely due to living circumstances, not having access to health care, things like that. I don't think, as far as I know, I don't think it's because of some co-infection type of relationship like we see with STIs. I think it's just basically the outcome of poverty. Okay. So symptoms of tuberculosis, in the beginning, early stages, you don't have any symptoms. Your immune system is kind of unaware of what's happening. But later stages, you will actually have severe coughing for weeks, and typically you will cough up blood with this coughing, and you'll typically have, fever, weight loss, fatigue, weakness. You might even have night sweats. You don't necessarily always have every single symptom with these diseases, but we're giving you the most common symptoms. And this is to show you how severe different regions of the world are just struggling with these tuberculosis infections. So we can see these purple regions have very, very high amount of the percentage of the population that's infected, right? Whereas these orange areas are showing fewer infections, but it's not zero, right? In fact, the only place we're seeing zero are the places that are not inhabited by people. Since we started screening for tuberculosis, everyone who goes to public school, anyone who works for a public job, like you're working for the city, state, or county, or federal, like you should also have all of your vaccinations and your tuberculosis screening. Those are usually requirements. I believe here, right, being at a public school, even at the college level, they're supposed to require you to have all that documentation. And this is really important, because if we can find people who are TB positive and they didn't know they were TB positive, then we can get them treatment. And then also giving them treatment not only helps that individual, but it helps reduce the spread of the disease as well. So this has worked really well. Look at this decline over the years since we started testing. Other countries actually give a vaccine. We don't give the vaccine. We do the testing, the screening. We also see some interesting distribution of tuberculosis within people living in America. These ethnic groups of Asian Pacific Islanders seem to have the highest percentage of tuberculosis. And what you will see throughout this class is that there are different ethnic groups that have for some reason in their DNA is a slightly different, and makes them more susceptible. And we're talking like these are really tiny differences, right? All different ethnic groups, all humans are mostly identical when it comes to DNA, on the large scale, right? But when you start to look at individual genes, then you can start to see very slight differences, and sometimes that leads to more susceptibility of particular diseases. And so this is what we're seeing here. Pathogenesis. So step by step, let's look at the progression of the infection and symptoms. Okay, so in the alveoli, right here is the blood capillary that wraps around the alveoli, and then here is the inside of the alveoli. And here is your alveolar macrophage, right? That's always scanning the alveoli for anything that happens to get there and remove it. But what we'll see is that it started to do that, right? It ingested a tubercle bacillus. So unfortunately, this is another area where it can be confusing, is that instead of just calling it Mycobacterium tuberculosis, they call it a tubercle bacillus. So remember that that's the same thing. Okay, we're talking and trying to point that out in this image, right? So the little rod-shaped bacillus, right, bacteria, is the Mycobacterium tuberculosis bacterium. It's been ingested by the alveolar macrophage, but unfortunately, for the majority of these bacteria, they will not be killed by the macrophage. They'll survive and continue to reproduce. So the tubercle bacilli that reach the alveoli of the lung are ingested by the macrophages, but often survive. Infection is present, but no symptoms of disease yet. Okay. The macrophages recruit more macrophages to help try to control the infection. So tubercle bacilli are multiplying inside of the macrophage, which causes the macrophage to release chemicals like cytokines and enzymes, which stimulate more immune response. It's a chemotactic response that brings additional macrophages and other defensive cells, not shown in this image, to the area. These form a surrounding layer around the tubercle bacilli, and in turn this is going to form what we call an early tubercle. So again, I know the terminology is confusing, but the tubercle itself is like the mass that is containing the infection. Okay, so you're starting to form a mass. You're also getting lung inflammation at this point. You're going to start to have symptoms because all of these macrophages are releasing, right? They're trying to fight an infection and stimulate the immune response to do that. But the side effect of that is, damaging inflammation. So this is when the coughing is going to start. This is when the fever is going to start, right? Those onset of those symptoms. And this continues on until you get a very well-defined tubercle. So after a few weeks of this process that we just talked about here, after a few weeks, the disease symptoms are fully, in effect, right? They appear. Many of the macrophages will die, right? So you see these dark macrophages here. They have died, and that's going to release the tubercle bacilli that was once inside of them. And this then leads to what we call a caseous center. So that the aerobic tubercle bacilli do not grow super well in this environment here, this caseous center. So it is slow. Okay. However, just because they're not growing doesn't mean they're dead, right? So many of them will remain dormant, and this is the latent TB, and it puts the patient at great risk of a later reactivation. And if it does, so if this becomes disturbed and opens up, if this bursts open, then you can spread all of those bacteria throughout the body and have severe symptoms, severe form. Okay, so however, many remain dormant and serve as a basis for later reactivation of the disease. The disease may be arrested at this stage, and then the lesions become calcified. So we'll see, this outer layer of the tubercle, it's calcified, it's been walled off by the immune system. Now you see the presence of other defensive cells, as well as the macrophages. And you see this cavity, right, where you have all the bacteria in the middle, and then you have the macrophages that are infected, dead ones, and then living ones that are infected. And then you have all the macrophages and other cells that are alive and not infected, okay, trying to help control this infection. Okay, so in some individuals, disease symptoms appear as the mature tubercle is formed, and the disease progresses as the caseous center enlarges in a process called liquefaction. The caseous center becomes larger, forms an air-filled cavity, which then allows the bacteria to multiply outside of the macrophage, and this makes you more likely to then burst open. So liquefaction continues until the tubercle ruptures, allowing bacilli to spill into the bronchiole, and then it disseminates throughout the lungs, and it can also get into the circulatory system and the lymphatic system. Okay, so treatment is prolonged, multiple antibiotics. It's very hard to kill all of the bacteria, and so this is one of the reasons that tuberculosis is still so prevalent in many countries, because they don't have access to multiple antibiotics for 6 months, right? It's hard enough to get people in the United States to finish a 10-day treatment with antibiotics. So imagine going to another country where they are probably in poverty and trying to get them to take medication for 6 months. That's it's just not going to happen. So vaccines are really super important. We need to be able to have a vaccine program to vaccinate in these countries. Unfortunately, that's not going to help the people that are currently infected, but it can help to reduce the new infections with the new generations of people. We don't do the vaccine because we're able to be effective with controlling it by screening and then treatment. If you have been to another country and received the vaccine, you would need to be careful not to get the testing, the screening that we do, called the tuberculin skin test. You will test positive if you've had the vaccine. How the test works, it's a delayed immune response called delayed cell-mediated hypersensitivity. So you get the little small amount of tuberculin put just underneath the skin, makes a tiny little blister of that fluid. The body absorbs that fluid and it should just go away. You may have a tiny little mark. You come back in 48 to 72 hours to confirm that it actually did just go away. If it didn't, if it caused a reaction, right, this is a severe, right, like 15 or more millimeters, positive for any person with a normal functioning immune system. You do not need to memorize all the details of it'll be this small if it's a HIV infected person or a recently contracted infection. and then so on and so forth. Don't worry about memorizing this. It's just good to introduce you to these concepts so that if you do end up going into to the practice where you need to know this, it will at least not be foreign to you. Most of you probably already had this done multiple times throughout your life, but this is how it works, right? So this person's obviously positive. Someone with a small reaction, then you have to know more about the patient to determine whether or not that's a true positive or not. Okay. I think I will stop here. It's been a half hour, and then we will do another part of the video to finish up. There's not very much left, so you'll have another short video, and then that'll be it. All right, good job, guys.